Hi everyone, welcome back to the Pill to Know channel. Today we're diving into a topic that affects millions of people around the world. Hypertension. What is it? How do you know if you have it? And what does it really mean for your health? Whether you're here to learn more for yourself, to support a loved one, or just to stay informed, you're in the right place. So, grab a cup of tea, get comfortable, and let's break it all down, simply, clearly, and with your health in mind. Before we get started, just a quick but important reminder. This video is for educational purposes only. This is not a sponsored video, and we'll be using generic drug names to keep things unbiased. If you're considering any changes to your medications or treatment plan, please talk to your healthcare provider first. Your health is unique, and your care should be too. Why hypertension matters. Hypertension, high blood pressure, is often called the silent killer. It usually has no obvious symptoms, allowing damage to build up quietly over time. According to the CDC, in 2023, about 48.1% of U.S. adults, 119.9 million people, had high blood pressure, and it was a primary or contributing cause of more than 660,000 deaths. Among middle-aged adults, the remaining lifetime risk for developing hypertension is 80% to 90%, with earlier onset in men than women. It's the most prevalent risk factor for cardiovascular disease. Think coronary artery disease, heart failure, atrial fibrillation, stroke, dementia, and chronic kidney disease, and a leading cause of death and disability worldwide. Hypertension often travels with other risks. From 2017 to 2020, in the US, among adults with hypertension, 72.6% were overweight or obese, 16.6% were smokers, 12.3% had diabetes, 13.4% had chronic kidney disease. The good news? High blood pressure is modifiable. You can manage it. Definitions: adults non-pregnant. According to ACC or AHA, the American College of Cardiology and American Heart Association. Normal, systolic blood pressure, SBP, less than 120 millimeters of mercury, and diastolic blood pressure, DBP, less than 80 millimeters of mercury. Elevated, systolic 120 to 129 millimeters of mercury, and diastolic less than 80 millimeters of mercury. Stage 1 hypertension, systolic 130 to 139 millimeters of mercury, or diastolic 80 to 89 millimeters of mercury. Stage 2 hypertension, systolic greater than or equal to 140 millimeters of mercury, or diastolic greater than or equal to 90 millimeters of mercury. Definitions: pregnancy, according to ACOG, American College of Obstetricians and Gynecologists. Hypertension, systolic greater than or equal to 140 millimeters of mercury, and or diastolic greater than or equal to 90 millimeters of mercury. Severe range hypertension, systolic greater than or equal to 160 millimeters of mercury, and or diastolic greater than or equal to 110 millimeters of mercury. Diagnosis: getting an accurate reading is essential. Proper technique matters a lot. Preparation, positioning, environment, and equipment can all skew readings. Tips for accurate measurement: avoid caffeine, exercise, and smoking for at least 30 minutes beforehand, and empty your bladder. Use a validated device. See validatebp.org for the list of validated devices. Choose the correct cuff size for your arm. Place the cuff on a bare arm with the bottom above the elbow bend. Support your arm at heart level. Sit quietly for greater than or equal to 5 minutes. Feet flat, legs uncrossed, back supported. Don't talk or use your phone during the measurement. Measure in a temperature-controlled room. Take at least 2 readings, greater than or equal to 1 minute apart, then average them. Out-of-office monitoring might be needed in some cases to rule out white coat hypertension and masked hypertension. White coat hypertension, high at the clinic, normal at home, often anxiety-related. Masked hypertension, normal at the clinic, high at home. Home or ambulatory measurements help confirm diagnosis and catch both patterns. Causes: blood pressure reflects a blend of behavioral, environmental, hormonal, and genetic factors. Diet: high sodium, low potassium, excess alcohol, low fiber. Lifestyle: aging, obesity, low physical activity, sleep disturbances, psychosocial stress. Secondary hypertension: approximately 5% to 25%. Elevated blood pressure due to another condition. Treating the cause can significantly improve blood pressure. Common causes include obstructive sleep apnea, chronic kidney disease, primary aldosteronism, Conn's syndrome. Excess aldosterone leads to high blood pressure and low potassium. Renovascular hypertension, narrowing of the renal arteries. Medications, substances that may raise blood pressure. Excess alcohol and caffeine. Decongestants, phenylephrine, pseudoephedrine. Herbal supplements, such as ma huang and ephedra. Black licorice, NSAIDs, ibuprofen, naproxen. Recreational drugs, oral contraceptives. Prevention strategies. Lifestyle changes are powerful and foundational. Weight loss. For adults with overweight, obesity, aim for greater than or equal to 5% body weight reduction or greater than or equal to 3 kilograms per square meter drop in BMI. Expect about approximately 1 millimeter of mercury systolic blood pressure, pressure reduction per 1 kilogram lost. Dietary approaches to stop hypertension. Emphasize fruits, vegetables, whole grains, and low-fat, non-fat dairy for higher potassium, magnesium, calcium, and fiber. Sodium, reduce to less than 2,300 milligrams per day, ideally less than 1,500 milligrams per day. Potassium-enhanced salt substitutes can help in adults with normal kidney function. Alcohol, limit to less than or equal to 1 drink per day for women and less than or equal to 2 drinks per day for men. Exercise, aim for at least 150 minutes per week of moderate aerobic activity and or at least 2 days per week of resistance training. Stress management, practices like meditation, breathing techniques, or yoga can be useful adjuncts. Medical management, 2025 AHA and ACC Guideline, risk-based approach. A simple sequence of questions can guide when to start medication. 1. Is your average blood pressure greater than or equal to 140 over 90 millimeters of mercury? Yes. Initiate antihypertensive medications for primary or secondary prevention. No. Next question. 2. Do you have existing clinical CVD, such as coronary heart disease, stroke, heart failure? Yes. And systolic greater than or equal to 130 or diastolic greater than or equal to 80. Initiate medication for secondary prevention. No. Next question. 3. Do you have diabetes or chronic kidney disease, or is your 10-year prevent CVD risk greater than or equal to 7.5%? You can calculate risk here. Yes, and systolic greater than or equal to 130, or diastolic greater than or equal to 80. Initiate medication for secondary prevention. No. Meds are recommended only if systolic greater than or equal to 130, or diastolic greater than or equal to 80 after 3 to 6 months of lifestyle interventions. Classes of antihypertensive medications. Preferred first-line agents. 1. Thiazide-type diuretics, water pills. Examples: chlorthalidone, hydrochlorothiazide HCTZ, indapamide. Note: chlorthalidone has a longer half-life and is more potent than HCTZ on a milligram-to-milligram basis. How they work: inhibit sodium reabsorption in the distal convoluted tubule by approximately 3 to 5%, promoting natriuresis and diuresis, lowering intravascular volume and blood pressure. Precautions: monitor for low sodium and potassium and increased glucose, uric acid, and calcium. Watch patients with acute gout, if not on gout therapy. Tip: take in the morning to avoid nocturia. 2. Angiotensin-converting enzyme inhibitors, ACE inhibitors. Examples: benazepril, captopril, enalapril, lisinopril. Look for arpril ending. How they work: competitively inhibit angiotensin-converting enzyme leading to less angiotensin II, a potent vasoconstrictor, causing vasodilation and lower blood pressure. Precautions: do not combine with ARBs or direct renin inhibitors, aliskiren. Risk of hyperkalemia, especially with chronic kidney disease or potassium-sparing meds, such as spironolactone. Risk of acute renal failure when starting, higher in heart failure, CKD, or bilateral renal artery stenosis. Avoid with any history of angioedema from ACE inhibitors. Avoid in pregnancy. Tip: avoid potassium supplements and NSAIDs, ibuprofen, naproxen, to reduce hyperkalemia or acute kidney injury risk. 3. Angiotensin II receptor blocker, ARBs. Examples: candesartan, irbesartan, losartan, olmesartan, all ending in sartan. How they work: selectively block angiotensin II at the AT1 receptor, leading to vasodilation and lower blood pressure. Precautions: do not combine with ACE inhibitors or aliskiren. Risk of hyperkalemia and acute renal failure when initiating. Higher in heart failure, chronic kidney disease, bilateral renal artery stenosis. Avoid with a history of angioedema to ARBs. After ACE inhibitor-associated angioedema, ARBs may be used greater than or equal to 6 weeks after stopping ACE. Avoid in pregnancy. Tip: avoid potassium supplements and NSAIDs. 4. Dihydropyridine calcium channel blockers, DHPCCBS. Examples: amlodipine, felodipine, nicardipine sustained release, nifedipine long-acting. Look for dipine ending. How they work: block L-type calcium channels, reducing intracellular calcium 2+ in vascular smooth muscle, leading to vasodilation and lower blood pressure. Precautions: dose-related lower extremity edema, more common in women. Tip: avoid excess grapefruit juice. It can enhance blood pressure lowering and edema risk. Alternatives and special situations: non-dihydropyridines, calcium channel blocker, non-DHPCCBs. Examples: diltiazem extended release, verapamil. Avoid routine use with beta blockers. Risk of bradycardia and heart block. Do not use in heart failure reduced ejection fraction. Loop diuretics, also called as water pills. Examples: bemetanide, furosemide, torsemide. Often for symptomatic heart failure, preferred over thiazide in moderate to severe chronic kidney disease. Torsemide is longer acting, often preferred. Consider if thiazide causes hyponatremia, potassium-sparing diuretics. Examples: amiloride, triamterene. Minimal blood pressure effect as monotherapy. Combine with a thiazide for thiazide-induced hypokalemia. Avoid in significant chronic kidney disease. Aldosterone antagonists. Examples: eplerenone, spironolactone. Preferred in primary aldosteronism and resistant hypertension. Spironolactone. Higher risk of gynecomastia and impotence than eplerenone. Avoid with potassium supplements, other potassium-sparing diuretics, or significant renal dysfunction. Avoid in pregnancy. Beta blockers. Examples: atenolol, bisoprolol, carvedilol, labetalol. Not first line unless coronary heart disease or heart failure is present. Avoid abrupt cessation. Direct renin inhibitor, aliskiren the only agent in the class. Very long-acting. Similar precautions to ACE inhibitors or ARBs. Do not combine with ACE inhibitors or ARB. Alpha-1 blockers. Examples: doxazosin, prazosin, terazosin, all ending in zosin. Risk of orthostatic hypotension, especially in older adults. Notable first dose effect. Considered as second line for patients with symptomatic benign prostatic hypertrophy. Central alpha-2 agonists and other centrally acting agents. Examples: clonidine, methyldopa, guanfacine. Generally last line due to central nervous system side effects, especially in older adults. Do not stop clonidine abruptly due to risk of rebound hypertension. Taper slowly. Direct vasodilators. Examples: hydralazine, minoxidil, can cause sodium or water retention and reflex tachycardia. Use with a diuretic and a beta blocker. Hydralazine, risk of drug-induced lupus-like syndrome at higher doses. Minoxidil, can cause hirsutism and may induce pericardial effusion. Dual endothelin receptor antagonist, aprocitentan, the only member of the class. May cause mild to moderate fluid retention, usually within 4 to 6 weeks of therapy. Avoid in pregnancy. We know this is a lot to take in, so here are some key points to remember. Personalization is key. Choose therapy based on your conditions, such as diabetes, coronary heart disease, chronic kidney disease, heart failure. Risks such as electrolyte issues, angioedema, access and cost, and personal preferences. Goal: for individuals with hypertension, aim for systolic blood pressure less than 120 millimeters of mercury and diastolic blood pressure less than 80 millimeters of mercury to reduce cardiovascular risk. Monitor regularly. Check a basic metabolic panel 2 to 4 weeks after starting or adjusting antihypertensives to monitor renal function and electrolytes, sodium, potassium. ACE inhibitors, ARBs, and aldosterone antagonists may cause an expected eGFR dip up to approximately 30% via efferent arterial vasodilation. This short-term dip is often associated with long-term kidney protection and doesn't warrant stopping unless the decline is persistently greater than 30%. Monitor blood pressure with proper technique after initiation and dose changes to assess effectiveness. Coordinate care. Always consult your healthcare team before starting, changing, or stopping any medication. If you see multiple specialists, make sure each knows what others are prescribing. Some drugs affect blood pressure, such as pseudoephedrine, nicotine, and may require adjustments. If you enjoyed this video, don't forget to hit like and share it with others. Also, make sure to subscribe so you'll get notified when the next video drops. And more importantly, to help build a stronger Pill2No community. I'll include all the references in the description below. If you have any questions, feel free to leave a comment. Thanks for watching, and I'll see you in the next video. Let's stay healthy with Pill2No.